One of the biggest challenges in caregiving, whether by professionals or families, is caring for someone with delirium. What is delirium? Who gets it and why? And how do we manage it with or without medications?
Join us as we discuss these questions and more on this episode of Medical Timeout. Welcome to Medical Timeout, a podcast where we unpack all things palliative care. I'm Chinlin Ching.
And I'm Rashmi Kadilkar. Today, we'll focus on delirium as we continue our series on symptom management in palliative care. So, of the symptoms associated with serious illness, all of which obviously impact the patient, the one that may be the worst for families and caregivers is delirium. Not only does delirium mean that caregivers have to see their loved one suffering, but there may be new gaps in communication and connection because of the patient's delirium. The caregivers may worry about the risk of injury or other harm if their person is agitated. And on top of it, the symptom itself can limit effective treatment. So it's no wonder that delirium is a really common reason for seeking medical attention and even for hospital admissions.
You're right, Rashmi. This symptom doesn't just affect the patient, but also his or her circle of caregivers. Let's first talk about risk factors. Who is at risk for developing delirium? Being hospitalized, as you said, is itself a risk for delirium, which occurs in about a third of admitted patients and up to 80% of ICU patients. That's huge. Mm-hmm. The risk of post-operative delirium is 15 to 50%, depending on the type of surgery. And other important risk factors include older age, underlying brain disease like dementia, medical illness, polypharmacy, frailty, vision or hearing loss, and sleep deprivation. Delirium is associated with worse hospital outcomes and a higher morbidity and mortality rate. Older adults who develop delirium have a 1-year mortality of up to 50%. That's huge. So in addition to being a distressing and challenging symptom, delirium is important in prognosticating. So let's introduce our patient. Mrs. V, this time, is a 93-year-old with a history of COPD, Parkinson's disease with mild associated dementia, diabetes, and hypertension. She's being hospitalized for acute respiratory failure, I think from an aspiration pneumonia. When admitted, she's alert, she's fully interactive and oriented, she's self-directing, she's able to provide an accurate history. But now she's confused and doesn't know where she is. She keeps pulling at her sheets, pulling out her lines, trying to get out of bed. She almost fell a few times. She is refusing her medications and some other interventions. Rashmi, you're called to evaluate her and consider an order for restraints.
Ooh, restraints. I can see you shuddering at that.
I absolutely hate them.
Yes. Let's talk about delirium. So delirium is a symptom, or more precisely, a syndrome, rather than a disease. It's characterized by disturbances in consciousness with poor awareness, attention, and focus, plus changes in cognition, memory impairment, disorientation, and language ability. Sometimes it involves delusions and hallucinations. The important thing about delirium is that it tends to develop over a short time, like hours to days, not weeks to months, and it tends to fluctuate. So someone with delirium can be really confused during work rounds at 7 o'clock in the morning and perfectly lucid on attending rounds at 9 o'clock on the same day. And usually we think of delirious patients as restless, agitated, aggressive, hallucinating. And these are people who have hyperactive delirium. There is also a form of delirium called hypoactive delirium, in which case patients can be, confused, drowsy, withdrawn. They just seem like they're out of it. And this form of delirium goes unrecognized a lot of the time because we might mistake it for just fatigue or depression. But in the palliative care setting, it's actually more common for somebody to have hypoactive delirium as opposed to hyperactive delirium. And people can actually alternate between the two as well.
That's an important distinction. Rashmi, can you talk a little bit more about the difference between delirium and dementia?
Yes, because that's also a really important distinction. So, in a nutshell, delirium is hopefully a transient symptom or syndrome, and dementia is a disease. So, that means delirium comes on quickly and it fluctuates, and it can be really unpredictable. Dementia, in contrast, usually has a slow onset, like over months or actually years for most patients. And a given patient's manifestations of their dementia tend to be consistent. Delirious patients tend to be either agitated or lethargic, and they really have trouble paying attention to what's going on around them. Demented patients actually a lot of the time are awake and alert and pretty calm. Of course, delirium and dementia can coexist, but the way that you manage one versus the other is a little bit different. So even in people who are known to have dementia, it's really important to evaluate for delirium under the appropriate circumstances. So, Chinlin, what should we consider as we evaluate delirium? What are some of the potential causes?
So as always, a really thorough and good history and physical goes a long way, and lab values and can give us some clues. But some common causes are metabolic derangements, abnormalities in sodium, glucose, calcium are common, hypoxia or hypercapnia, kidney or liver failure, cancers that involve the brain or meninges, seizures, strokes, or something neurologic. Surgeries and procedures, as we mentioned, can cause post-op delirium and infections and many, many others, including just being hospitalized, as we had mentioned.
Right, and I want to highlight a couple more causes of delirium. So first of all, just uncontrolled symptoms, particularly pain and urinary retention and constipation can absolutely cause delirium, especially in older adults. And then another really important cause is polypharmacy. So it is so important that we do a thorough medication review in patients who have delirium. So a lot of times we give the blame to medicines like opioids and benzodiazepines, and we'll talk about that going forward. But other culprits include antihistamines, anticholinergic medications, and this can include things like diphenhydramine or Benadryl, antidepressants, muscle relaxants, corticosteroids, as we mentioned in a past episode, and even nonsteroidal medications like ibuprofen. All of these can cause delirium in some patients. And then we shouldn't forget about things like alcohol, marijuana, or about withdrawal from medications or withdrawal from other substances.
Right, and I want to echo your sentiment that benzodiazepines and opioids are often blamed first for any type of delirium. And I really want to implore our listeners to be a little bit more thoughtful. If a patient's been on these medications chronically, then the chances of them causing acute delirium are quite low unless there's been a big change in dose or something else. And stopping chronic opioids and benzodiazepines abruptly could actually cause delirium through withdrawal symptoms. There's a condition called terminal delirium or terminal agitation, which we'll talk about in a future episode, which is restlessness that develops in up to 88% of patients in the last days or weeks of life. And so, again, trying to be thoughtful about the cause is really important.
Right, because even something like terminal delirium is a diagnosis of exclusion. So even at the end of life, we can still look for reversible etiologies. And so that's the first line treatment and can also help to prevent delirium.
Right. So we can first start by trying to modify the environment, right? Can we put the patient someplace with natural light or stimulate light and day changes if they're in a room without a window, have a clock in the room, make sure that the patient has his or her glasses, hearing aids, other assistive devices that can help them communicate with their surroundings, try to have a known face around someone familiar, engage the patient in activities they enjoy during the day, minimize ambient sights and sounds like the TV, unless they're really huge fans of Judge Judy. But otherwise, try to limit those types of agitating sounds. Mm-hmm. Try to limit lines or what we call tethers, so IVs, catheters, other things if possible in a hospital.
Right. And at the same time, we should be looking for and addressing underlying causes, provided, of course, as we've been saying all along, that doing that is within the patient's goals of care. So We can maybe correct electrolyte abnormalities using IV fluids. We can give supplemental oxygen. We can give antibiotics. We should treat people's pain. We should treat their constipation. We should treat their urinary retention. We should streamline the medication list, since we mentioned that polypharmacy is such a prominent cause of delirium, especially in hospitalized older adults. You might need to make trade-offs sometimes, like, should you put a catheter in somebody who's delirious while at the same time you want to limit their tethers? You might have to decide which of the things is more pressing and choose to treat the symptom versus limit the tethers. And so what you have to do is consider what's likely and then keep reassessing. Reassess every time you make an intervention, see what the response to that intervention has been.
Right. And so as we wrap up the discussion on non-pharmacologic treatment of delirium, I want to go back to physical restraints, which brought up such a visceral response from me. Please do not use physical restraints if at all possible. They can worsen anxiety and fear and agitation and pain, and they definitely increase the risk of injury. Plus, they reduce a patient's dignity. It's not dignified to have mitts on or to be tied down into a bed. So if the risk of harm to a patient or others is high, and all other measures have been unsuccessful, trying to have face-to-face time, right, trying to redirect them, all the things that we had just mentioned, then physical restraints might be a last resort for safety, but make sure there's clear documentation of need and reassessment regularly in short intervals. That has to be a must.
Right. And a lot of hospital systems, including our own system, have guidelines for when you can use restraints, and there are mechanisms built right into the medical record that prompt providers to reassess frequently and document that need. So thankfully, there's a lot more recognition about how harmful restraints can be, and ways to mitigate that use and limit that use as much as possible. So these clinical pathways or these guidelines that hospitals have for treatment of delirium also talk about, how do you evaluate, how do you report delirium, and then they also talk about protocols for non-medication management for delirium. They also talk about medication management. Now, we should not be medicating patients to minimize our distress. As the professional caregivers, as family caregivers, it's not about what's distressing to us alone. But sometimes patients have delirium that distresses them, or they have behaviors that are harmful to them, like if they keep trying to get out of bed and they're at high risk for falls. And sometimes their behaviors are risky to other people, like if they're agitated and they keep swatting at people or hitting or spitting or any of those things. So sometimes people do need medications, not to minimize caregiver distress, but to minimize harm to the patient and maybe to others. When we need medications for delirium, our usual first choice are medications in the antipsychotic class. We talked about these earlier when we talked about nausea, and this is maybe a more familiar use for them, since now we're talking about neurologic and psychiatric symptoms. So there's not a robust evidence base for all of these antipsychotics in the use of delirium. We typically will choose haloperidol as our first-line treatment for delirium. It's a good choice because it has really few anticholinergic side effects, especially in the short term, and it's available both orally and parenterally, and more on that parenteral part in just a second. So again, in the short term and in the low doses that we use for delirium, the risk of extrapyramidal side effects and hypotension is also pretty low. So what we will typically start is somewhere between 0.5 milligram to 1 milligram of haloperidol. We'll do that every 4 to 6 hours as needed, and we'll do that either PO or IV or subcutaneously. We don't use 5 to 10 milligrams at a time. We use a tenth of that, and we use IV and sub-Q administration, not intramuscular administration. Let me highlight that again, not intramuscular administration. If it's appropriate, whatever dose we're choosing and whatever route we're choosing, we will increase the dose and maybe schedule doses if needed to control the patient's symptoms.
Also, atypical antipsychotics such as risperidone at like 0.25 or zero point 0.5 milligram doses, olanzapine at 2.5 milligrams, or quetiapine or Seroquel, about 25 milligrams, 1 or 2 times a day, are alternatives to haloperidol. Although they're significantly more costly than haloperidol, they're also not available parenterally, so you can't give them IV. There are some dissolvable sublingual options like Zydus, but assuming the symptoms resolve with time or with treatment of underlying causes, we work to taper the doses over a few days. So these aren't meant to be chronic medications. They're not meant to be scheduled all the time. It's really used acutely with hopes of improvement. Now, we'll note here that all antipsychotics carry a black box warning of increased mortality, especially in dementia-related psychosis. As always, reassessment of the risks and burdens versus the benefits is really important. And remember, antipsychotics should be used cautiously in patients with neurodegenerative diseases and conditions like ALS or progressive supranuclear palsy, and never in patients with advanced Parkinson's disease or dementia with Lewy body disease.
Right. So for these patients for whom some of these antipsychotics are contraindicated, and also for some other patients, another class of medications that can be useful is benzodiazepines, which we've also discussed multiple times before. So in our practice, we will use lorazepam, 0.5 milligram to 1 milligram orally or parenterally, about every 4 hours as needed. Now, benzos do come with their own significant risks, like worsening confusion or sedation and falls, especially in older adults. Some people actually get a paradoxical reaction, too, where their agitation gets worse when they get benzodiazepines. So that's something that's important to watch for. So benzos are most appropriate in the short term, and we really try to reserve them for people who really have significant anxiety, delirium with readily reversible causes, so that we know that they're going to be short term. And also in end-of-life situations. So rarely, and usually in the context of terminal delirium, which we mentioned a little while ago, a patient has delirium symptoms that are so severe and refractory to everything that we've tried. And in those cases, something called proportionate palliative sedation might be warranted. So we'll mention that here. We'll talk about it in more detail in our episode that's coming up about intensive symptom management at end of life. And it's important to know that if you are considering proportionate palliative sedation at any time, the input of a palliative care specialist is pretty much mandatory.
Yes, that's important to note here. The medications we've mentioned already, Rashmi, are for what you mentioned as hyperactive delirium with restlessness and agitation. For hypoactive delirium, some clinicians might actually reach for methylphenidate, or what we know it as Ritalin. And that's kind of surprising. But the data for it, its efficacy is kind of limited. It's kind of a, end of 1 or 2 success in your career kind of thing. But the mainstay of treatment for these patients is really finding out what's reversible, providing supportive measures. But if you do have someone without much risk factors for exacerbating mania or psychosis, a trial of methylphenidate would be worth it.
Yeah, and as you mentioned, the mainstay of treatment for hypoactive delirium is supportive measures. And what's really important in all kinds of delirium is to provide ongoing education and support for patients and for caregivers, in addition to any medications. Because remember, this is a symptom that can alter communication and connections between patients and their families and caregivers. And because the symptom fluctuates, nobody can predict what's going to happen. I can't predict, the patient can't predict, the family can't predict how the patient's going to be in the next hour. So it's important for us to, acknowledge and be upfront about these realities with the patient and caregiver. And we should also be upfront about the reality that we may not fix the symptom. We may just be managing it in the short term, and it may go away and come back, and we're going to have to get back into it with whatever the measures are. And then for that reason, we also need to make sure that caregivers know who their resources are. Their physicians, or other medical providers involved in the care? Are there potentially paid supports that they can put into place? Can they tap into organizations like the Alzheimer's Association? People, especially those who are on hospice, might have access to additional resources even beyond that, like they might have home health aides, there might be volunteer services, there might be things like musical therapy. Caregiving can be really isolating. So especially when a caregiver is dealing with something like delirium, which alters even the one connection that they do have, it's really important to show caregivers that they're not alone.
Right. And I think I want to go back to the point that you made that we want to distinguish this from dementia, but sometimes delirium is the beginning of dementia. Right. You know, there are patients who probably just hang on by their fingertips to reality in their very well curated environment, and then you remove them from that very comfortable environment and everything unravels. Right. And you name it delirium because it's new and we hope it's short term, but it could actually never go away and become the diagnosis of dementia. Right. So that's important to educate caregivers about as well. Right. But let's go back to our patient, Mrs. V. So she's our lady in her 90s with COPD and Parkinson's disease, admitted for aspiration pneumonia. You facilitate a move for her to a room with a big window, so she's exposed to natural light. Her family steps up visits so that she can see a familiar face all the time. Between you and her nurse, you redirect her so that she can get a dose of parenteral Haldol. And then she continues to take haloperidol pretty much every 8 hours for the next day or so. As her antibiotics kick in, that's treating her aspiration pneumonia, her delirium begins to resolve, thankfully, and her haloperidol is tapered and eventually discontinued. On discharge, her mental status is at her baseline and her family is educated in what to do if she develops these symptoms at home. Well done.
Gosh, thanks a lot.
Good job.
Thanks. So let's review what we've discussed today. Delirium is a syndrome that's characterized by fluctuating changes in attention, orientation, and memory that develop over hours to days. It can be hyperactive or more commonly hypoactive delirium. There are multiple risk factors and causes, including older age, hospitalization, metabolic abnormalities, physical illness, and medications. The management involves addressing the underlying issues, maybe using medications like antipsychotics, and then providing supportive care and education to the family and to the patient as well, if the patient is able to receive those measures.
And delirium is associated with poor increased morbidity or mortality. So an episode of delirium might actually be a trigger for a goals of care discussion. Mm-hmm. As always, it's essential to keep these goals in mind when thinking about what treatment is appropriate for the person.
So, Chinlin, we're at our segment in the podcast now where we address issues around DEI, diversity, equity, and inclusion. What kinds of DEI issues do we need to be mindful of as they pertain to delirium?
So, we mentioned one of the most distressing things about delirium is the inability to communicate well with the patient and with the caregivers. So I think one thing to remember is before labeling someone as delirious or confused, have you removed any other barriers to communication? And what I mentioned about this is language or cultural barriers are the important DEI things to think about. So I'll give you an example. There was a patient once who we took care of who was labeled as delirious and confused in her chart in the emergency department. Turns out she only spoke Mandarin Chinese. And also the information sharing amongst her family was different than what we would expect. In her culture, her daughter was very protective of the information that she knew about her own disease. So this is a patient who had lung disease. Her daughter did not want her to know how serious it was or the prognosis. And so the lack of information sharing was something that was cultural, that wasn't taken into account for, and the patient was labeled as delirious because she didn't know much about her own disease. So that is something to be mindful for.
Yeah. And let's move on now to our pet peeves, the things that just drive us absolutely crazy regarding delirium. So one of mine is when people blame delirium on one specific thing, when there actually could be many factors coming into play. So most commonly, we hear people blaming UTIs for delirium, or we hear people blaming opioids for delirium. The thing is that when it comes to UTIs, in older adults, a lot of people have asymptomatic bacteriuria that really has nothing to do with anything that's going on clinically, and specifically that they may not have a UTI that's causing their delirium. It's probably a combination of lots of other factors. So if people don't have other UTI symptoms like frequency and dysuria and maybe fevers, and not just a foul odor to the urine, but all of these other things as well, it's really important to look for other causes, maybe in addition, but certainly maybe instead of. And then when it comes to opioids, going back to something that we talked about a little bit earlier, just because somebody is on an opioid doesn't mean that the opioid is causing their delirium, especially if they've been on that opioid long term. So how about for you? What makes you crazy about this symptom?
To quote Frank Costanza, I have a lot of problems and you're all going to hear about it, but you've already heard about the two that are my pet peeves. One is restraints. It's undignified and it's scary. Yeah. Don't do it. You've heard my spiel about it. We can do better. The second one is I am Haldol. If a delirious patient doesn't have IV access, haloperidol can be given through a subcutaneous disc. An IM needle is large and painful. Please don't order IM Haldol on your cachectic geriatric patient who's delirious. It may actually turn into like an intraosseous injection. It's terrible. Please don't do it.
All right. Well, on that note, let's wrap it up here. Remember, going forward, we would love to hear from you. Please send us your questions, your comments, or any topic suggestions for the future by emailing medical_timeout@urmc.rochester.edu. This podcast is supported by a grant from the System Transformation Fund through the Safety Net and Program Support Office with UR Medicine. We give our thanks to Dr. Kevin McCormick and to Nancy Scott for spearheading this grant and also for their commitment to palliative care education.
Thank you to Levi Ganji for our beautiful music. Huge thanks to Nick Davis and Genesee Valley Media for recording, editing, and producing the podcast.
And thank you to all of you for taking this medical timeout with us. We hope you'll join us the next time when we'll talk about intensive symptom management at the end of life. Until then, have a great couple of weeks.